I have come up with this again one more important topic, the atrial fibrillation, which is the most common arrhythmia encountered in ICU patients. It is a supraventricular arrhythmia characterized by chaotic atrial rhythm and irregular ventricular response. And as a consequence, the atrial contractile function is lost and the ventricles undergo variable filling. Okay, and due to this variable filling, there may be instances of hypotension and compromise of cardiac performance, and also myocardial ischemia and reduced organ perfusion or even cardiogenic shock. Atrial fibrillation occurring in patients with no prior atrial fibrillation diagnosis are considered as new onset atrial fibrillations. And today we will talk about epidemiology, risk factors, and the management, and also the anticoagulation. So all these points we are going to discuss in this video of about 20 to 30 minutes. So let's start. So the incidence of new onset atrial fibrillation in ICU ranges from 5% to 46%, depending upon the type of ICU. Suppose the patient is in medical ICU, the rate of or incidence of atrial fibrillation is 15%. Okay. Otherwise, there is a variability, as I said, 5% to 46% in other ICUs, depending upon the type of patients. There are various risk factors. Some are patient or host factors, and sometimes they are ICU diagnosis, admission diagnosis. So we will talk about the factors which are present in patients who which contribute to atrial fibrillation, new onset atrial fibrillation, in which fluid overload and dehydration both are important risk factor. Then hypoxemia, hypotension, anemia, acid-base abnormalities, acidosis or alkalosis, and electrolyte abnormalities such as hypokalemia, hypomagnesemia both contribute to atrial fibrillation. So these are correctable or modifiable factors which you should always look in any patient. Then there are some risk factors which are present but you cannot do much about that, like disease severity. If it is a critical illness severity is very high, which is designated by Apache score more than 20, or advanced age, this is also non-modifiable, male sex, obesity, right? So you always take care of these modifiable risk factors first in any patient in ICU or potential to develop the atrial fibrillation. What about other risk factors? So there are some ICU admission diagnosis like shock, sepsis, heart failure with pulmonary edema, myocardial infarctions, blunt thoracic trauma. This is very important. Any patient who is having blunt thoracic trauma or thoracic intervention, the post-operative patients, these patients also at higher risk of atrial fibrillation. Then there are some comorbidities like ischemic heart, okay, or previous calcium channel blocker use. These two are very important comorbidities which are attributing to atrial fibrillation. Then in ICU, some interventions like if patient is on dopamine, arrhythmogenic vasopressors like dopamine or dobutamine or epinephrine even. So these are arrhythmogenic vasopressors, epinephrine. And pulmonary artery catheter also is one of the important risk factor. Okay, so what about the consequence? What about outcomes? Why do we pay so much attention to new onset atrial fibrillation? Because it contributes to morbidity and mortality both. If you talk about mortality, the mortality is actually increased as demonstrated by various literature. Up to 45% of patients may die in hospital itself after discharge from ICU. That is why we have to be very, very serious about atrial fibrillation to control the rhythm. And regarding the morbidity, studies in the liver transplant, they have reported increased graft failure and renal failure, renal injury, and prolonged hospital stay. And in patients with sepsis, there is increased incidence of ischemic stroke and also subsequent hospitalization for heart failure in future. So these are important comorbidities which are related to atrial fibrillation. And in patients who develop new onset atrial fibrillation in ICU, they can go on to develop persistent or chronic atrial fibrillation in about 18% of patients which who are discharged from ICU remain in atrial fibrillation, according to this research published in 2012. Now, how will you manage? So, what about guidelines? Do we have guidelines for the new onset atrial fibrillation? So, remember that the guidelines which are there, which are published, are basically providing the management of acute AF, but they have excluded, these guidelines have excluded the patient in ICU. Okay, so the evidence-based and expert consensus on which these guidelines are based does not appear to include patients in ICU settings. And in future, we will have guidelines for new onset atrial fibrillation ICU as well. Okay, so management guidelines are not available for ICU patients. So management lies in finding out and addressing the risk factors, basically, which I have already told you in previous slides: the anemia, hypoxemia, hypotension, uh, fluid balance, etc. Okay, so these are important treatable precipitating factors which you should always pay attention to prevent and to manage the atrial fibrillation. Okay, even hyperthyroidism, this is important comorbidity. Okay, which you should always look and always send thyroid profile for all the patients who are having atrial fibrillation and they are not correctable with other causes. Right. So once you have paid attention to the risk factors, now what are the other options? So if patient is hemodynamically unstable with rapid ventricular response, then you must assess whether the cause of their instability is the arrhythmia or underlying condition. If the tachycardia is a compensatory mechanism, synchronized cardioversion is unlikely to provide any benefit. Okay, so always ask yourself whether the past AF is compensatory to hypotension or the cause of hypotension. There may be two things: either AF is contributing to hypotension or hypotension is contributing to AF. If hypotension is contributing to AF, then address hypotension, AF will resolve itself. If AF is contributing to hypotension, then you have to take care of AF, and probably in this case, synchronized cardioversion will be very useful. Okay, and remember that DC cardioversion in critically ill patients have much lower conversion rate. Only 35% of patients respond to DC cardioversion. Okay, and if and then many of them, revert to AF within 48 hours. So that is the reason you should always combine synchronized cardioversion with some antiarrhythmic and adjunct antiarrhythmic to improve the success of cardioversion and maintenance of normal sinus rhythm, NSR. So which rate controller is the best? That is very important question people ask, and from the limited evidence available, beta blockers or amiodarone may be superior to calcium channel blockers as the first line therapy in undifferentiated patients in ICU. Calcium channel blockers are not preferred because they contribute to more cardiovascular instability, and the success rate to control the rhythm is lower compared to amiodarone or beta blockers. They are not very good rate controller or rhythm controller. So calcium channel blockers may result in more cardiovascular instability, one, and second, the rhythm control is not as good as beta blocker or amiodarone. That is the reason CCBs are not favored. Beta blockers may be equivalent to amiodarone. If you compare beta blockers, amiodarone, various studies are available. So they have shown to be equivalent to amiodarone for rhythm control. But beta blockers may be reasonable first choice treatment due to current evidence of decreased mortality. Okay, so if we talk about the mortality, beta blockers are superior to amiodarone as per studies, and they have improved or better heart rate control. Okay, so they are better rate controller compared to amiodarone. Now if somebody asks you which one is better, which beta blocker is better to control the atrial fibrillation rate, so there are various choices like bisoprolol or metoprolol succinate. They may be first choice beta blockers in patients who are otherwise having acute AF, but they are not in ICU. But in ICU patients, um, bisoprolol, you can say bisoprolol is better compared to metoprolol, because it is more cardioselective. Okay, and but problem is that bisoprolol can cause more bradycardia compared to metoprolol. So it's still you have to see the risk and benefit if you are selecting metoprolol over the bisoprolol. In ICU patients, because they are very unstable, so esmolol may be better choice. Okay, so esmolol has advantage of having the short acting, very short half-life. Okay, that is why effect of beta blocker on cardiovascular instability is uh, is unpredictable in such patient. That is why esmolol is better. Okay, because of short act, you can always stop if patient is developing hemodynamic stability, right? But in case of metoprolol or bisoprolol, you may have to wait, and you may have to start norepinephrine infusion, okay, to maintain the blood pressure. So that is why esmolol is considered better than rest of tools. Amiodarone has a slower onset compared to beta blocker or diltiazem. However, it has been shown to successfully reduce the ventricular rate and improve the blood pressure in critically ill patients with AF refractory to other treatments, and it is quite safe for patients with structural heart disease. Okay, so in patients with structural heart disease, amiodarone may be preferred over beta blocker or even calcium channel blocker, right? So this is important. But remember that long-term use of amiodarone is associated with the side effects. Okay, that is the problem. It may contribute to pulmonary toxicity and acute respiratory distress syndrome, as has been seen in one of the research. In surgical ICU patient, amiodarone use was associated with higher rate of pulmonary toxicity and ARDS. Okay, so amiodarone may be better choice in patients who have structural heart disease or in patients who have reduced ejection fraction. Now, digoxin. What is the role of digoxin? Digoxin should not be considered as the first line option for the rate control due to its slow onset of action. That is disadvantage. Okay, it can never be used as a first line option. Better agents are available like beta blocker or amiodarone, even CCB. So that is why it has been kept last choice. Its mechanism of action is to reduce the conduction through the AV node by the vagal stimulation, decreasing its utility during times of adrenergic stress. So it's not very helpful. But it can be safely combined with the beta blocker or calcium channel blocker, or in patients who have reduced ejection fraction, digoxin may be good, but it is always the last choice compared to amiodarone. Right. Now, what about the magnesium sulfate? People use magnesium sulfate a lot, especially in emergency department. There is a strong safety profile of magnesium and similar rate of cardioversion to sinus rhythm compared with amiodarone. Head-to-head comparison was made, and there is a systematic analysis also available comparing magnesium with amiodarone, and they found that magnesium is a reasonable choice prior to amiodarone if rhythm control strategy is chosen. In consideration of its high safety profile, magnesium sulfate administration play a very important role in emergency department patient as per this study. Okay, so yes, magnesium sulfate has a role, especially if you do the magnesium level and if you find it less than 0.9 or 0.7, better to give magnesium sulfate. Okay, that will relieve the symptoms and will definitely cardiovert. Now, regarding the therapeutic anticoagulation, patients with critical illness and AF have twofold higher risk of developing in-hospital ischemic stroke compared to those without AF. So this is important fact. But they also have higher bleeding risk if you use the therapeutic anticoagulation and often require invasive procedures that may necessitate interruptions of anticoagulation very often, and decisions regarding anticoagulation of critically ill patients are quite complex. Based on very little evidence available, therapeutic anticoagulation is not needed for new onset atrial fibrillation. As per recent large cohort study focusing on patients with sepsis, investigating the practice pattern, this study was published in JAMA in 2016. So it looked at the practice pattern and outcomes associated with the systemic anticoagulation during hospitalization with AF and sepsis. This is a very large study comprising about 1,13,511 patients. And hospital, as per this study, hospital practices for the use of parenteral anticoagulation in patients with AF during sepsis varied widely, with one third of hospitals deviating significantly from mean rates of anticoagulation use. But very important factor in this study which was given was that the rates of ischemic stroke during sepsis were generally low, less than 1% or just around 1%. And the change in the incidence of ischemic stroke with therapeutic anticoagulation was quite insignificant. So as per this study, there is no use of using anticoagulation, therapeutic anticoagulation for the ischemic stroke. Rather, this study shows that the bleeding risk was higher compared to prophylactic or no anticoagulation. So if you are using therapeutic anticoagulation in ICU patients for AF, new onset AF, definitely the risk of bleeding is higher and the therapeutic benefit is quite less. That is the change in the incidence of ischemic stroke. That is why we have to balance the risk and benefit in each and every patient, and still limited evidence is available to suggest the therapeutic anticoagulation in new onset atrial fibrillation in ICU. For the patients who are admitted in ICU with the chronic AF, still there is benefit of using therapeutic anticoagulation as per your cardiologist, but otherwise evidence is quite weak to use therapeutic anticoagulation for the new onset atrial fibrillation in ICU. And the last slide regarding the treatment algorithm, any patient who is coming with new onset atrial fibrillation, what you are going to do first is to assess the hemodynamic instability and to find out the risk factors. If patient is having hemodynamic instability due to AF, then better to go for direct current cardioversion and simultaneously treat all the precipitators, especially the hypotension, hypoxia, and dehydration or overload or pulmonary edema, etc., and also the electrolyte abnormalities. And if you have addressed that and still AF is present, then you have to go for antiarrhythmics, better ones are the beta blockers and amiodarone, and probably the patient will revert from AF. And if it is not, then this is the case of resistant or refractory or chronic AF. I mean, it's going to become chronic AF or persistent AF. Then you can't do anything much about that. You have to talk to your cardiologist friend. Probably after discharge, this patient will require electrical therapy. So that's all for today. Thank you so much for your attention. I was very fast. I think I was very focused, and I'm sure that you will get benefit from this presentation. Follow me on YouTube and Instagram and ask any queries you have in critical care medicine, especially academics or even clinical queries will be answered. And best wishes for your exams if you are training. Thank you. Bye bye.